No?
How about now? Can you hear me now?
Oh, yes. Yes. Thank you.
Oh, excellent. I'm actually doing this from my cell phone today. We're having issues with our phone lines. So if for any reason you need me to speak up, please do interrupt and let me know. But as long as everybody can hear me now, if I can get an okay on that, I'll get started.
Yeah, we can hear you clearly.
Okay, excellent. Well, hi everybody. My name is Fiona Wolfe. I'm from Empire Justice Centre, and our webinar today is Access to Services in Medicaid Managed Care. So let's get started. How do I advance the page on this? Oh, there we go. Okay, so we're going to focus today on mainstream managed care. Most people, after they're approved for Medicaid, are going to be enrolling in a managed care plan. The plans that are available are going to vary county by county, and we've got a link there to the New York State Department of Health that gives a directory of the managed care plans by county. So you can have a look in there to see what's available for the people you'll be working with in your location. As I said, most people are going to have to join a plan unless they are exempt or excluded from managed care. Some examples of people who can stay with regular Medicaid would be people who are living in facilities for the developmentally disabled, residents of long-term alcohol or substance use facilities, Native Americans, or adults who are already in waiver programs like the NHTD, OPWDD, or TBI. Some examples of people who must stay with regular Medicaid, who'd be excluded from managed care, will be people who are in hospice programs at the times of enrollment. Those are living in state psychiatric or residential treatment facilities, people who are getting Medicaid after a spend down, or anyone else who's on another full benefit health insurance, they would be excluded. You don't have to enroll if you're approved for an exemption, but those who are exempted can enroll if they choose to. Okay, so how does managed care work in the background? DOH pays the insurance companies per member per month to cover the cost of care. And then the plan will pay for the care rather than fee-for-service Medicaid. In fee-for-service, beneficiaries can go to any doctor or provider who takes Medicaid, and the provider would be billing Medicaid directly every time they're providing a service to the beneficiary. With managed care, the plan is paid at that capitated rate, that flat fee per month, and that's to provide for nearly all of the beneficiary's healthcare needs. Managed care plans must cover Medicaid benefits at a minimum. Medicaid can be retroactive for up to 3 months, as long as the person is eligible in those 3 months. It's going to pay for comprehensive medically necessary services, including medicine, supplies, durable medical equipment, doctor visits, hospital inpatient and outpatient, labs and x-rays, etc. Managed care enrollees may only see doctors and health providers that are within their plan's network, and they must follow the particular plan rules for accessing care, and those are going to vary plan to plan. A member is going to be assigned a primary care provider, and they must go through that provider in order to get a referral for any specialty care and also for any prior authorizations that they might need for non-emergency hospitalizations and other services. And as I said, the network providers are going to bill the plan directly and not New York State Medicaid. So let's turn to look at the pharmacy benefit under managed care. In New York State, the pharmacy benefit covers both medically necessary and over-the-counter drugs. We have a mandatory generic dispense program, which means that prior authorization is required for any medication that is not generic. Medicare Part D is going to replace Medicaid coverage whenever a person has both. So if you have a dual eligible, so they're Medicare eligible and they're applying for Medicaid, they must take Medicare or they're going to be denied Medicaid. Now this next screen sets out a brief list of prescription drugs that are covered by Medicaid for dual eligible members. As I said, Medicaid generally doesn't cover drugs that Part D won't cover, except these listed drugs. Medicaid will cover certain prescribed vitamins and certain other types of over-the-counter meds that are not covered under Part D. So they'll cover for duals whenever a doctor writes a script. Also worth noting there that Medicaid will not cover any compounded prescriptions or medications. And there's a link at the bottom there if anybody's looking for more information on those prescription drugs that are covered. Briefly, let's take a look at the co-payment amounts. Medicaid co-payment amounts are currently $3 for non-preferred brand name drugs, $1 for preferred brand names or generics, and then 50 cents for over-the-counter non-prescription drugs. Important to note that somebody cannot be denied medications if the patient cannot pay, and there are certain beneficiaries that cannot be charged co-pays, including children under age 21, and those that are participating in the Home and Community-Based Services waiver or the TBI waiver participants. There's a link there that will that has a list of full list of anybody who can't be charged co-pays, but those are just some common examples that you might come across. And also there is a $200 annual maximum co-pay that runs from April 1st through till March 31st. So once you cap out at 200, there won't be any more co-pays for pharmacy. So what should you do if your client has trouble filling a prescription? Firstly, you need to find out whether your client is in a Medicaid managed care plan, and if so, which plan. Then you want to be checking whether the particular drug that they're trying to get access to is on the plan's formulary, and if so, whether any restrictions apply. Now, the client that you're working with might not always have this information available for you. So oftentimes the client's provider, doctor or pharmacist, can be a good source here to try and get that information. Also, we've got a link there to the New York State Medicaid Managed Care Pharmacy Benefit Information Center, and that's a link to the website. We'll be looking at this in more detail a few slides further on, but that website has links to all of the managed care plans and the contact info. It also has a feature that lets you search the various drugs and compare the formularies for each plan. And it has information such as the Department of Health helpline. So formularies are obviously quite important when you're looking at drugs that clients are trying to get access to. Firstly, what is a formulary? Well, it's a list of drugs that are preferred by a particular health plan. And it is going to, vary from plan to plan. Health plans will usually only cover drugs, brand name or generic, that are on this preferred list that they have put out there. And, they're always going to be looking at which drugs are most cost effective. So it's going to be the drugs that they have deemed to be effective and cost effective. As I said, each plan has its own formulary. So for people that you're working with who have chronic conditions, such as HIV, it's imperative that they know ahead of time that their medications are going to be on their plan list. Every formulary that a plan has must be comparable to fee-for-service Medicaid formulary. We've got a link there that sends you through to the eMedNey website, and that will give information on the fee-for-service Medicaid formulary if you're interested in having a look at that. And as I mentioned before, the New York State Medicaid Managed Care Pharmacy Benefit Information Center website has all the information about the plans, and that website is updated by DOH on a quarterly basis. Plans are able to set their own quantity limits, which means that health plans can limit quantity and dosage frequency, but they must do consistent with how the FDA has approved the use of a particular drug. So really, they'd be looking at things like daily dosing recommendations. So you need to check carefully on the drug lookup list for any limits that might be listed, because this is something that could impact quite heavily on your client's day-to-day needs. There's a standard prior authorization form for all plans. Prior authorization, so when a drug requires prior authorization, for example, the plan is deemed that there's safety concerns or potentially there's another lower cost alternative available, then it's the enrollee's healthcare provider that must seek the approval before a drug can be covered. When they're seeking prior authorization, they need to provide a rationale for covering that particular drug, and there is also an option to fast track a prior authorization request as well. So I've mentioned it a few times, but let's have a look at the MMC formulary website, the DOH website. It's a screenshot there of the first page that you'll see when you click on the links that we had in the prior slides. And we've circled there the drug lookup search. So if you were to click on that, that would give you the option to search any particular drug. You can also click on the icons that are on the first page to pull up more information on any particular managed care plan. So the slide that's up now, if you were to click on Fidelis Care, this is just an example of the helpful information that would pop up relative to Fidelis. You have an example card there, customer service number, pharmacy help desk, the number to call to initiate a prior authorization request. And as you can see, you can click on all those various links that will take you through to more information specific to that plan. So this really is a very helpful website. This next screen is an example of a drug lookup search. So the example that we've pulled up is if you were to type in metolazone, which is a common hypertension drug, with all plans checked off, this is the chart that would be produced. It gives you a list of the various plans that will cover this drug. The generic, as you can see in that first, the middle table there, everything has a C beside it. That means it is covered. And then we have the brand name, and the abbreviation NC shows that the brand is not covered. So again, this would be your starting point if you're wanting to check for any particular named drug for one of your clients. So if a drug is not covered under your client's current plan, but it is covered under other plans that are available in your client's county, certainly something worth considering is changing plans. That can sometimes be the best option available. So timing is going to be important. If you're working with somebody who is dual eligible, remember that they get their drugs through Medicare Part D or Medicare Advantage. Dual eligibles can switch plan once per calendar quarter, and that would take effect the first of the next month. And they can do that for the first 9 months of the year. So they have a little bit more flexibility in terms of options to change plans. For everyone else, if a necessary drug is not covered by your client's current plan, but is potentially covered by another, as I said, changing plans could be a very good option, but you do need to look at the timing. Within the first 90 days after initial enrollment, an enrollee is free to change plans, but you will then be locked in for the remaining 9 months. So really, during that first 90-day period, that's the time when people should be making sure that all of their required medications are covered and making sure that there isn't a better option out there, because once you get into that 9-month lock-in period, you're stuck there. After 12 months enrollment in a plan, then they would be free to switch. Just a little note at the end there, although we are talking about drug coverage right now, remember to always verify that your client's doctor or their providers participate in any new plan that you're looking at as well. So there's several factors to keep in mind. A few more notes on prescription coverage. Prescriber prevails. The provider has the final say for their patient on whether certain medications are medically necessary for certain listed drug classes. And this applies even if the drugs are not on the particular plan's formulary. We've listed the drugs there. It's not a particularly long list. We have anti-rejection, endocrine, antidepressants, atypical antipsychotics, antiretrovirals, seizure, epilepsy, hematologic, and immunologic therapeutics. So prescriber prevails applies just for those listed drugs. However, even in those drug classes, the prescriber is still going to need to demonstrate reasonable professional judgment and will probably need to supply the plan with requested information or clinical documentation to show that those medications are actually medically necessary in the circumstances for their particular patient. It's also possible to obtain mail order or specialty drugs at any retail network pharmacy if that retail network pharmacy has agreed to a price is comparable to the mail order specialty price. So that's an option as well. So what sort of potential issues could your clients be facing? First of all, you might find that your client's plan is not on that Medicaid managed care pharmacy benefit website that we've referenced and looked at. A few questions to ask. Is it a commercial plan? Perhaps you're looking at something completely different. Also, is your client Medicare eligible? As we talked about, then if so, it would be the Medicare formulary that you'd be looking at. If the drug is not listed on the plan, or step therapy or quantity limits might apply, then you're going to be looking at prior authorization. And we've already touched on that before. Step therapy, that would be when the health plan requires that one or more lower cost drugs in the same drug class or in a proven clinical alternative drug class, that they must be tried before they'll cover the requested drug. So as I said, if you're looking at prior authorization, that's the provider that needs to start that process off using the standard prior authorization form, and it should be processed within 48 hours. There's also options to request formulary exceptions with plans. Formulary exception, that's the type of coverage determination request for getting any drug that isn't on a plan's formulary approved. Some types of drugs are just not covered. They're not listed on any plan's formularies. Some examples would be any drugs that were deemed for cosmetic purposes. But all health plans must have a process in place to review these requests for any non-covered drugs. So if any request is going in, it starts with the provider, and they would need to be explaining why it would be medically necessary for the patient and why it should be approved in their circumstances. And as we touched on before, another option to remember is that depending on the timing and depending on how long they have been enrolled, changing plans to one that covers the drug your client needs might oftentimes be the best option. So what can you do when the managed care plan denies access to a drug that's necessary for your client? All plans are required to have internal and external review processes. Some plans might develop special procedures for drug denials, so you always want to look at the member handbook, because that should have information on any plan-specific procedures. Now, starting back in April 2018, whenever a plan denies approval or discontinues a drug that had previously been approved, the enrollee has to receive an initial adverse determination. Exhaustion also applies. So the enrollee must first request an internal plan appeal and wait for the plan's decision before they can take any additional steps. Once the plan completes its internal review, they're going to issue their final decision. If it's going to be an adverse decision, then the enrollee is going to receive a final adverse determination. And that would cover the exhaustion requirement. After they receive a final adverse determination, then the enrollee has the right to request a fair hearing. Now, there is a process known as deemed exhaustion. So if a plan does not provide that final adverse determination in the required time limit, which would be 30 calendar days would be the standard, or 72 hours if it had been an expedited process. If no final determination within the allocated time period, then that would equate to deemed exhaustion, and your client could move ahead and request a fair hearing without waiting for the late final adverse determination. Aid continuing becomes a very important issue, particularly if a drug is being reduced or terminated. Then you want to make sure that your client gets aid continuing during the appeal process, because it could take some time. You need to request continued access to the particular drug while awaiting that plan appeal and or potential fair hearing. And there are important time limits there. It's a very short time window that you get to request aid continuing to have it be effective. You have only 10 days of the final adverse determination or before the effective date. So if you're working with a client on a possible appeal, just take note of those time limits and make sure that you get your aid continuing request in before the deadline expires. Any consumers who are experiencing problems with access to prescription drugs under their managed care plan should really always be filing a complaint with the State Department, the managed care hotline, and we've got I think we have information at the end of the slide, and if not, I'll make sure we give it out for the contact information, because it's always important to report and make sure that all complaints are filed and documented. External appeal, that's the option that kicks in once you've exhausted your internal appeal options with your plan. If an enrollee receives a plan notice denying the internal appeal, that notice is going to explain their right to request an external appeal. If the reason for the denial is because the plan has determined the service or the drug is not medically necessary or is experimental or investigational. You can request request an external appeal even if you're also requesting a fair hearing. You can start both routes off at the same time. External appeal is a different route than going down the fair hearing route. Ultimately, you're going to have the appeal reviewed by a different state agency. It's going to be DFS, rather than if you go down the fair hearing route, then the appeal will be determined by a DOH administrative law judge. And just a point to note there that the fair hearing decision is always going to trump the external appeal decision. So sometimes it can just be tactical as to which one to move forward with. Fair hearings tend to be scheduled faster than going down the external appeal route. So oftentimes we'll counsel clients on both options, but then ultimately pick whichever is going to get them the faster result if we think it's going to be the favourable route. Gosh, I put this in many times in these slides, but again, just a note there that if somebody is within that first 90 days of enrolment or they're past the first 12 months of enrolment, remember, switching plans to improve access to medications could be the fastest way to get them coverage rather than waiting out an appeal.
Fiona?
Yeah.
Someone wrote down a question, and I just want to see if you can clarify it. Someone wrote, it was my understanding that if a client was dual eligible, they could only have basic Medicare ABD and could not enroll in Medicare Advantage. And that might be open to someone even here. Gio, you want to clarify?
Yeah, sure. Yeah, if somebody's dual eligible, they still have the option to enroll into a Medicare Advantage plan. In fact, some Medicare Advantage plans are special needs plans, which are specifically for dual eligible individuals, so they'd be able to access those as well. But yes, they'd be able to enroll into just a regular Medicare Advantage plan if that's their choice.
Thank you. Oh, go ahead, Fiona. That was the only question.
Oh, thank you. And if any other questions, because the way my screen is, I can't actually see if any questions are being typed. So interrupt me if anything else comes up.
Sounds good. Thanks.
Okay, dental networks. The care plans are have to cover some limited dental. The networks must be sufficient enough to cover the plan's service area, and they must include the listed services that we've set out there in the slide: an oral surgeon, pediatric dentist, TMD specialist, must have available oral, maxillofacial, I can't even say this, prosthodontic specialist. I'm not even going to attempt to say the next because I'll butcher it. And also those serving special needs such as HIV patients. Dental services for children are provided as part of Medicaid's Early Periodic Screening, Diagnosis and Treatment Program, the EPSDT. Under that program, managed care enrollees from birth until age 21 are going to have access to services such as periodic oral evaluations, preventative, restorative and emergency dental care. The provider manual sets out that means children should receive routine preventative dental care every 6 months, and that additional visits should be based upon the dentist's assessment of the child's individual needs. If anyone's looking for more information on the EPSDT, it would really be the provider manual for that program that they would need to be having a look at. But it's just a note in there really that it would be the linking up between the Medicaid managed care and those particular services that are available for children for dental. Dental care that would be covered is set out on this screen. It's kind of a dense slide here. We have preventive dental care, preventive, prophylactic and other routine dental care services, supplies and prosthetics required to alleviate a serious health condition, including one which affects employability, and includes up to 4 annual fluoride varnish treatments for children up to age 7. And then orthodontic work, what's going to be covered is going to vary greatly depending on whether someone's up to age 21 or over 21. Once you're over 21, any orthodontic work has to be in connection with necessary surgical treatment. What's not on this slide, and really what I've come across, and I think what probably most of our colleagues have come across, is that there's a lot of dental services that are going to be excluded. Things that would be excluded: dental implants unless medically necessary, and that would need a prior approval request and a lot of supporting documentation from your client's dentist. Fixed bridge work, and there's some exceptions there, but that's often excluded. Full or partial dentures, root canal therapy for people over 21. Again, there's exceptions that, unless it's very medically necessary is the best way I can describe it. Crown lengthening, replacement of dentures, any dental work for cosmetic reasons, and any sort of experimental procedure. I can only talk to my own experience of working with clients here, but we've found that dental coverage is very, very difficult to get. Care coordination. Managed care plans have to provide coordinated care for their enrollees with high needs. So looking at populations with chronic illnesses, HIV, or with physical developmental disabilities. Plans should be screening automatically using their data to identify their high need populations, and also those needing long-term services and supports. Member Services Department is frequently the care coordination unit for the managed care plans. All health plans should have a Member Services Department that should be available to answer questions or help resolve any problems that enrollees are having with their providers or their access to healthcare within the plan. Member services are supposed to help their plan members that need special accommodations or extra support. So that would be the starting contact point for anyone who's needing help scheduling their healthcare appointments, assistance completing forms, or even things as simple as finding and locating medical offices that are wheelchair accessible or offer any other accommodations that their members might need. They should be able to provide readily available booklets in large print or audio format for anyone who has difficulties with hearing or speaking. And also, transitional care services. So if, for example, your client's provider is leaving the health plan or, they need information about other available providers, Member Services is the place that's supposed to be distributing and assisting their members with that information to make sure that, ongoing care is not interrupted. And that would also apply if somebody was changing into a new plan.
Fiona?
Yes.
Hi, and I just saw your email about also adding Amanda and Alexia.
No problem.
There were two questions or statements about dental. And I know you moved on from that, but one question, if you think a plan's dental network is inadequate, who do you go to? Who would you go to?
Complaints DOH, I think would probably be would be step one. If anyone else has any wonderful ideas, I'd invite them to shout them out.
Diane. Go ahead, Diane.
I echo that suggestion. I think file a grievance with the plan. If you can't find a network provider for dental, we just pulled a lot of dental data back to 2011, and one of the big services that we provide is helping clients find an in-network dentist. So, if the clients can't find it and you can't find it, filing a grievance with the plan, asking them to pay out of network if you can't find an in-network dentist, and that gives you get internal and external appeal rights for that, right? If there's a network adequacy issue. And then also, like you said, filing a complaint with the Department of Health, the Office of Managed Care. They keep track of all the different kinds of complaints that they get, and they're getting a lot of complaints about the same issue. It's really useful in terms of kind of policy advocacy.
And I guess that answers Cheryl's statement. Cheryl mentioned that finding dental work in northern New York is a challenge. Some kids have to travel over 4 hours for major dental work. So I guess just filing a complaint, is that?
Yeah, so I'm not sure if your particular case, what kind of insurance they have, if it's Medicaid, but generally the network adequacy rule for specific kinds of specialists is 30 minutes, 30 miles. So they are supposed to be providing specialists within that distance and time frame.
Okay.
So that certainly they should be approving an out-of-network dentist that's closer. I think sometimes the problem upstate is that there physically isn't a dentist that's closer for them to. They're happy to approve out-of-network up there because they know, but the dentists don't exist.
Right. Cheryl, we can follow up more after the webinar. And I think that's
thank you. I think that's the same issues that our clients face as well in upstate New York. It might just be that several hours away is the closest specialist to be able to carry out the dental work. Absolutely.
Right. Diane has one more thing to say.
I have. It's related, but a little bit unrelated. But it's sometimes a fix for folks if you've exhausted all avenues for dental coverage for clients. We unfortunately a lot of times have to use our New York Times neediest cases and get clients that grant because their insurance simply does not cover what they need. It's either an exclusion or they can't prove medical necessity according to very, very strict criteria. And so it's important to know that that's a resource for folks.
Great.
They have to be living in New York City. Thank you, Nakia. Yeah, they have to be living in New York City. And they have to have, like I said, exhausted all insurance options. So you have to do all the rounds of appeals and all that stuff.
Thanks, Diane. We're all set, Fiona.
No, thank you, Diane. And just again, like a kind of add-on comment on that, sometimes we found that it depends on the provider as well. Like getting the dental coverage can be so difficult, even when you have a provider saying, yes, it is medically necessary, to jump through these really excruciatingly exact guidelines on what they have to satisfy in order for it to be medically necessary. So even when you have the provider working as hard as they can to, submit documentation, it's still a challenge. Absolutely. Okay, so I'll move on from dental now because I feel like we could probably talk about how bad it is for a long time. Just touching briefly here on parity laws for mental health and substance use disorder health insurance coverage. We are lucky here. We have laws put in place, New York State and federal laws that require most comprehensive health insurance plans to cover medically necessary mental health services and manage mental health or substance use benefits in the same way as they manage medical and surgical benefits without any additional limitations. That's really what those federal laws and state laws that are referenced on this slide do. What does that mean? That means that insurance plans are forbidden to require someone to fail first at a lower level of care before they can cover the treatment that's recommended by someone's doctor or therapist, such as inpatient hospitalization. The parity laws require managed care plans to use the following medical necessity criteria when assessing for mental health services: evidence-based, peer-reviewed, age-appropriate, and approved by the Office of Mental Health. And if a service is being denied, any denial notice that the plan sends must include the specific reason for the denial, the relevant denial code, the meaning of the denial code, and a description of those standards that they have used in denying the claim with a reference to the specific plan provisions that are being relied on in order to uphold the denial.
Fiona, this is Nakia. I have a question. So we get a lot of clients who are court ordered. I don't know if you mentioned that. Sorry if I zoned out a bit. But where clients are court ordered to go through a substance, treatment. And I wanted to know, are health plans at that point mandatory or required to cover those services, or they will still need to go through the medical necessity process And if they find that the plan, say, is not medically necessary, then what happens? Are they forced now to pay out of pocket because it's court ordered?
So that's a really interesting question. I've never come across that fact pattern. I put it out there to anyone in the group if anyone has and wants to answer. Otherwise, it's something I would happily look into, Nikia, because I think that's interesting.
Amanda, I also unmuted in case you have a response.
So was the question, if the treatment was court ordered, does it still have to go through medical necessity?
Yes. And is the plan required to cover it?
I believe so, yes. I mean, I would have to double check. I mean, I know that they still have to go through Medicaid approval and all of that stuff still. And I think that it still has to go. I would have to double check just to be safe.
This is Diane. I know that in the Medicaid managed care model contract, plans are required to cover court-ordered treatment, but these are HMOs, they're managed care plans. They're still allowed to put these claims through utilization review, and CHAMP sees those occasionally. I will say that they're not the kind of case that we see very often, where somebody in Medicaid managed care is being denied SUD treatment. And if their Medicaid plan is denying, it's post treatment, so it's not that they're discharged from treatment and balance bills. They're usually not in the few cases that I've seen and given TA on to CHAMP. But really interesting question.
Thanks. So I'm going to place Amanda back on mute, okay? And Fiona, we're all set.
Thank you. Okay, so quick overview of just the different types of managed care plans. We've obviously been talking about mainstream managed care, but we also have managed long-term care plans, health homes, health and recovery plans, and HIV special needs programs, the HIV SNPs. I don't have a slide on it, but I'm just going to talk briefly about managed long-term care, because if we went into too much detail on this one, I think it would take up an entire presentation. But as you all know, managed long-term care is the delivery of long-term services to people who are chronically ill or disabled and who wish to stay in their homes and communities. And to be honest, MLTC plans are where I do predominantly the most of my work right now. Those seem to be the issues that are taking up a lot of our time, with lots of people facing reductions left, right, and centre. Enrollment in an MLTC plan is mandatory for those who are dual eligible and over 21 years of age and need community-based long-term services for more than 120 days. Voluntary for those who are dual eligible between the ages of 18 and 21. Yeah, I'm not going to go into any more detail on MLTC because, as I said, we could go on and on and on about their problems. So let's turn instead to health homes. What are health homes? A group of health care plus service providers working together to make sure that you get the care and services that you need. In order to be eligible for health home services, the enrollee must be enrolled in Medicaid and must have 2 or more chronic conditions. That would include, for example, substance use disorder, asthma, diabetes, or have one single qualifying chronic condition. Examples of the single qualifying condition would be HIV, AIDS, or serious mental illness, or serious emotional disturbance or complex trauma in children. The care management under health homes will involve health providers, behavioural health and SUD services, connecting enrollees to the necessary medications, housing, helping with applying and recertifying for social services, and really any other support services as are deemed necessary. Health homes are available in each county, and if you click on the link that we have there in the presentation, that will take you through to the list per county. And the full list of the qualifying conditions is also set out there in one of the links. So the care managers in the health homes should verify referrals for eligibility in Medicaid, help members renewing Medicaid, and helping anyone who might be eligible for retroactive coverage, and just their continuing eligibility to be in the health home program. For those who are 21 and over who may be eligible for the services, they'll be identified through claims and encounter data that the plans are receiving. And if they're found eligible, will be assigned to a care manager. For folk who are under 21 who may be eligible for health home services, the state has developed the Medicaid Analytics Performance Portal, Health Home Tracking System, referral portal, but that requires a referral source. So either the managed care plan, care management agencies, local government units, local Department of Social Services will be feeding information into that. Community referrals can come from providers or entities, including physicians, emergency departments, community-based providers, supported housing providers, shelters, or even family members. For individuals who have intellectual and developmental disabilities, they were transitioned into Care Coordination Organisation, or CCO, health homes in July 2018, and that was part of the first phase of OPWDD transitioning into managed care. The CCOs provide person-centered integrated care model life plans. So it'll be a team of providers and care managers working together to provide health and behavioural health services, community and social support, LTSS, dental and other services, in addition to the OPWDD services that the individuals would have been receiving. Coverage is going to vary county by county. The link there on the slide shows coverage by county for each of the listed care coordination organizations. Turning now to health and recovery plans, or HARP. HARP is a managed care product for those with significant behavioural needs or substance use disorder needs, and it also integrates physical care needs. So HARPs must be qualified by New York State and must have specialised expertise in these areas, including tools and protocols that are not part of most medical plans. In order to be eligible, somebody must be identified through their use of behavioural health services or by functional impairment. They must be Medicaid eligible, and the individuals are going to work with care managers to sort through which home and community-based services they will be able to receive. The idea here is that it coordinates their physical and behavioural health care, as well as non-Medicaid support and medications. And then finally, we have the HIV SNPs, the HIV Special Needs Plans, only available in New York City, unfortunately. I think we wish that these were rolled out throughout the rest of the state. But these specialised plans are designed to meet the needs of those living with HIV or AIDS. Now, you can still be eligible if you're HIV negative if the person is homeless or transgender. Dependent children can also enroll. And the SNP plans cover all Medicaid services and, in addition, HIV specialist primary care physician, HIV care coordination services. They'll provide additional information about HIV medications and side effects, treatment adherence services, and also HIV prevention and risk reduction education for those members that are HIV negative. You can choose during Medicaid enrollment to be enrolled in an MMC or an HIV SNP. Clients who are receiving Medicaid through the marketplace, they can enroll in SNPs there. And clients with Medicaid through HRA would call Medicaid choice in order to enroll in a SNP. And there's still a link there to the model contract to anyone who's looking for more information about these specialised plans. And that is pretty much the end of the presentation. There's a list of references here on the next slide. I think these were a lot of the links that we had embedded in earlier slides. If anyone wants to have a further look at those. And then finally, just a list of resources. And I noticed, Nikia, that you had asked that we add in the complaint information for DOH. I forgot to do that, so I'm just going to say it right now. The Managed Care Complaint Unit telephone number for DOH is 1-800-206-8125. And there's also an email address, which is managedcarecomplaint@health.my.gov. And as has been stressed a couple of times by various people, it's worth putting these in, because if the data isn't captured, if the complaints aren't made, then there's nothing to track. So we'd encourage people to be doing that as well. And apologies for not putting that into the list of resources. And that's the end of the presentation. So if anyone's got any more questions.
Any questions around the room?
Thank you, Fiona. I'm checking to see if there's any questions on the webinar. And let's see if anyone raised their hands. I see no questions for upstate. Any downstate questions? No? All right, I think we're all set. Thank you so much, Fiona.
And I'm glad you were all able to hear me. As I said, I just was shouting into my cell phone.
Yeah, no, we heard you perfectly. Thank you. And I think that completes today's training and the monthly meeting. Upstate, we have our monthly meeting at 1. Thank you, everyone.
Thank you so much.
Thanks.